Good afternoon. So we are planning on having a question and answer session at the end. We have some time set aside so that we can hold your questions till then. It'll be, I think, more efficient. So thank you for having me here, and it's a pleasure to be again at the Society of Pediatric Pathology. It's a really fun place, fun meeting, and hopefully we will learn something together. So when looking at benign lymphadenopathies, this whole course is an interactive, sort of the five of us are exemplified here. This shows you the Great Lakes are interconnected, so are our talks. This is on the side wall of the Art Institute of Chicago. And so what we're going to be leading off from one to the other and talking about related entities. So my outline includes incidental lymph nodes that you may get as part of other surgeries, congenital malformations, whatever, that they are repairing or going in for surgery and you just happen to get a lymph node. That's one group of nodes that you get. The second group that you get are regional lymph nodes for when the patient has an obvious malignancy and they're doing a staging. So how you evaluate them and what your differential diagnosis is going to be different depending on that setting. The third group is evaluation of lymphadenopathy, meaning that the lymph nodes are enlarged, and this is for diagnosis without knowing anything much else. There is no other tissue diagnosis so far when you're starting to look at it. I'm, of course, going to focus on the benign aspect of it. So when you have these lymph nodes, you can look at them by pattern of involvement, which is how we all start out with. As a surgical pathologist, you have a specimen, you look at the pattern, and then you're going to decide what to do next. By etiology is more like a textbook picture in which, if you already know what the etiology is, then you can go through a differential diagnosis. But that's more for learning about the diseases. In the back of your mind, when you're looking at any lymph node, as Kamran said, you need to make sure that you know whether the patient is immunocompromised or not, because your differential diagnosis will be different from that. So in preparing for this talk, I found this one publication that actually has multiple very, very nice review papers on state-of-the-art in seminars in diagnostic pathology. It's a special issue, and it's on benign disorders of the lymph nodes. Came out last year. It's the volume 35. The whole volume is devoted to benign lymph nodes, and I found it very useful. And so a number of my references that are coming later are from this issue. Starting with the normal lymph node. When you are going to look at a lymph node, you have to remember that you want to look at the cortex, the paracortex, the medulla, and the sinuses separately to decide what the pattern is. And you also need to remember the location of the lymph node, because your findings are going to be different depending on whether it's a head and neck node or an abdominal node, because the incidental inclusions that you're looking for will depend upon the location. It can be from epithelium, mesothelium, they can be nevus cells, which can be very problematic, and I'm going to focus on those, or just some proteinaceous material like in Tam-Horsfeld proteins in abdominal lymph nodes. So starting from the top, here is a head and neck intraparotid lymph node, which was taken out as part of a staging for a parotid tumor. And there are both cystic as well as solid areas in it. You may not have all the components in every case, but you do have to remember that benign intranodal salivary gland tissue is very common, and you just have to remember to recognize it and not take it for being a malignancy or a metastasis. Having multiple types of glands makes life easier if you have both the serous component, although here there are some ducts here you can recognize, makes it very simple to say that this is really a benign inclusion. The second main differential in head and neck lymph nodes, especially in the lateral or even in the midline lymph nodes, can be the thyroid tissue. So there is a large amount of literature debating how to differentiate metastatic thyroid from benign rests. And there is a school of thought that thinks that there are no such thing as benign rests in lymph nodes. They're all metastatic thyroid malignancies. But certainly, I think that there are areas in which you have very benign-looking rest, especially when it involves the right location, and the patient may or may not have actually a thyroid lesion that you're evaluating. The neck lymph node may be taken out for something else. But if there are absolutely no signs of malignancy, the cells are small, and there is nothing else going on, we do call them benign rests, and they do occur, although they are rare. In the mediastinum, the lymph nodes can contain bronchial glands, and again, the glands can be mixed. You have both mucinous and serous glands, and so those would be benign. And we see them often in any age group and any lesion. Epithelial inclusions in the abdomen can be a little bit more challenging because you are sometimes looking for, especially in the pediatric population, if you're looking for an epithelial lesion to be in a lymph node, they can be cystic, they can be ciliated or endosalpingiosis. They can be small, as shown here, but they look benign. Their location tends to be more peripheral, as in here in the capsule. And they're usually not effacing the architecture or not in more than one or two, although I have seen them in more than one or two lymph nodes in a given patient. You can also get mesothelial inclusions that can be very worrisome because they're not that easy to recognize, and calretinin and WT1 stains are very helpful. One of the differential diagnoses for nevus cell rest is, of course, metastatic melanoma. We know that melanomas are rare in children, but they do occur in patients, especially in spitzoid melanomas, or when you're evaluating giant nevi, which have changed, and now they're doing a lymph node dissection, or are doing a sentinel lymph node biopsy. So the one thing to remember is nevus cell rests have only been described in lymph nodes that drain skin, not in any of the abdominal or other lymph nodes. So if you find a melanocytic tumor or lesion in an abdominal lymph node, that's going to be a metastasis because rests just don't occur where the skin is not being drained. So in order to call something a benign rest, there are several criteria that are published, and they're very useful. So vast majority of the time, the rest will be in the capsule, as shown here. It tends to be very well defined. There is not much atypia in the cells, and there are no mitotic figures, which is also a very helpful feature. So immunohistochemistry can be also, so if the location is not that typical, or if the rest is large, or if the lesion is pigmented, which it can be because you can get pigmented blue nevi in lymph nodes, and the morphology may not be easy to see. You may have to bleach the lesion. But the nevus cells are S100 and melan-A positive, which would be similar to melanomas. But in contrast to melanomas, they are P16 positive and HMB45 negative, which is actually a very useful combination because in contrast, here is a melanoma which is HMB45 positive and P16 negative. So with the combination of this panel, you should be able to sort them out. If there is still a problem, you can do Ki67 or a proliferation marker. The most important thing to remember for that would be that you need to do a double stain because you need to make sure that the proliferation marker that you're interpreting is actually in the melanocytes and not in the lymphoid cells that are next door. So we typically will do a melan-A, which is a cytoplasmic stain, together with a Ki67, which would be brown and nuclear, and then you could certainly make that difference. So just remember that nevoid cells are very common in lymph nodes as rests. And especially in the pediatric population, you don't want to overcall those. Okay. So that was for the benign rests that you would see in different locations in the body. Now we are looking at a lymph node that's being biopsied because it's enlarged, and they want a diagnosis. You should look at the pattern. Are the follicles more enlarged or hyperplastic, or is the lesion interfollicular? We may think about the patterns, but you also have to remember that the patterns overlap. There are diseases that will have more than one. So it's not 100%, but it's a way to think about how you're going to look at a slide. Starting with the follicular pattern. The one that we see most common is nonspecific. You just see an enlarged lymph node, there's a follicular hyperplasia, you really don't know what's going on, and it's perfectly okay to make that diagnosis of non-specific follicular hyperplasia, but you have to do that only after you know an extensive clinical history, because sometimes the diagnosis lies in the clinical findings and not in the path findings. But you do need to then write a note and say, based on the clinical finding of this, that, or the other, this is consistent with, So some of the things to remember that you may or may not know at the time of looking at the lymph node is the patient HIV positive, as Kamran said? And then where is the main finding? So I'm going to go over a few of the diseases here. So this is a very typical non-specific diagnosis. This was a 10-year-old who had an intraoral, what they thought was a cheek mass. So they really didn't even call it a lymph node. But on histology, it's clearly an encapsulated lymph node. There's a subcapsular sinus. There is follicular hyperplasia because the follicles are large. They vary in size. Some of them are very irregular. But as you look at them, they still have a polarity, the darker and the lighter, and they are rimmed by mature small lymphocytes, the mantle zone all around them. And so this one, something like this, you can sign out as follicular hyperplasia because there was nothing else that was going on in there. In the spectrum of follicular hyperplasia, what you do need to watch out for is how large are the follicles. Here is one that is, hyperplastic. Maybe that's a normal follicle. This one is hyperplastic, so is that one. But then look at these that are under the capsule. These are gigantic. The size of this is at least 3 or 4 times the other follicles. So when you start getting giant follicles, you have to look around and say, well, what else is going on? And so because the lesion may not be uniform throughout that lymph node. And you do have to submit the whole face of the lymph node to evaluate it. Here is one, so you can see a very sharply defined follicle with a nice mature lymphocytes at the edge. But then this one is not that sharply defined. The edges are kind of fuzzy, and that's because these mantle cells, small cells, are infiltrating into the germinal center. And not only are the small B cells infiltrating, there are also lots of macrophages that are infiltrating into the edge of the germinal center and making it fuzzy. So the fuzzy outline should make you think of progressive transformation of germinal centers. This can cause massive lymphadenopathy. A lymph node can be up to 5 centimeters. And this is the hallmark disease in which you get giant follicles. The small lymphocytes can be typed. They are IgM, typically IgM and IgD positive, and you do see those histiocytes. Now, it is important to recognize this entity because this one is self-limiting. If it is benign, it is benign. It doesn't progress to Hodgkin's disease or Hodgkin's lymphoma. You have to remember to look for Hodgkin lymphoma because Hodgkin can often be accompanied by changes that are those of PTGC. So you do need to do your markers. They're not the classic Hodgkin sites, so you're not really looking for Reed-Sternberg cells, but you're looking for the popcorn cells. So that needs to be kept in mind. Continuing with the follicular lesions, here is Castleman disease, which we used to didn't think that much. We didn't know as much about before when Dr. Castleman originally described it. He described it as an isolated lesion with this sclerotic pattern, having 2 follicles, 2 germinal centers in the same is very classic, and then this lollipop appearance because of the blood vessel coming in. The hyaline vascular variant is more common. The plasma cell variant has multiple plasma cells. You need to make sure that they're not clonal, but the important thing about Castleman disease to remember is it unicentric or multicentric? Because they really are different diseases. The unicentric can be treated with just resection and nothing else happens. You make the diagnosis. This is often the hyaline vascular type. It could be either type, but it's relatively benign. That doesn't progress. Is not associated with other diseases. Whereas the multicentric variant can be totally different diseases. It can be HHV8 positive or HHV8 negative and idiopathic. And moving in the multicentric, you have to remember that it can be life-threatening and it can result in end organ damage. A subset of these are due to dysregulation of IL-6, which is a genetic upregulation of it, and these patients present with systemic symptoms, and they need to be treated really aggressively, almost like you would treat a malignancy. Not only just IL-6, but there are other cytokines that can be elevated and they can be detected clinically or serologically. If HHV8 positive, it can be aggressive and it can progress to HHV positive large B-cell lymphoma. So these are not all benign lesions. And this multi-system disease with thrombocytopenia, ascites, fibrosis, fever, renal dysfunction, organomegaly has a very prolonged course. And histologically, it just looks like Castleman's disease, but clinically it behaves very differently. There can be aggressive flares, and a minority of patients can die of this disease as well. So that was Castleman disease, that a subset of them are more aggressive. Moving to the interfollicular pattern. The interfollicular pattern is based on between the follicles being either immunoblasts, histiocytes, different cells that are in it. So we'll start with the immunoblastic reactions. In pediatric population, obviously you're thinking EBV-related diseases first, but also remember that there are many things that can cause these immunoblastic reactions, and that may not be the only pattern. So for example, in juvenile rheumatoid arthritis, you also get follicular hyperplasia. In SLE, you can get hyperplasia as well as necrosis, and so on. So multiple patterns are common in reactive conditions as well. So giving you an example, this is a 16-year-old with median arcuate ligament syndrome, irritable bowel syndrome, and chronic pancreatitis. So with that complicated history, the clinicians were thinking more, could this be an autoimmune phenomenon? Is she relatively immunosuppressed? Does she have some infection? And could this be progressing to a lymphoma? So thus a lymph node biopsy is performed. And what you see at the lower power is that there is a germinal center here, but the space between the centers is markedly expanded by larger cells as well as a mixture of some small cells in between. So not diagnostic by itself, but you certainly would do an EBER for EBV, and this was strikingly positive. So EBV-related proliferations in children are, again, a wide spectrum. Most of us are positive by age 19, but if you're younger, if you get exposed to EBV when you're a few years old, it's most often asymptomatic, and we don't even know that we've been exposed. However, people who get exposed as teenagers will get infectious mononucleosis and its similar symptoms, so the lymph node would be reactive if the lymph node was biopsied. The time that we do see it is if the presentation is atypical, as in the previous case, or they're really thinking the lymph nodes are enlarging rapidly, and they're thinking that it is either an indeterminate malignancy, or the EBV has driven the malignant process. Similarly, if the patient has had a transplant, there would be a whole spectrum of EBV-driven lesions that will be addressed later. And the EBV positive patients can also present as hemophagocytic lymphohistiocytosis, which I don't have time to go into today. But that should also be, you should be aware that EBV can have multiple histologic findings. So moving on now to the next case, group of interfollicular patterns. This is a 5-year-old male with fever, arthritis, and lymphadenopathy. So already with just that clinical background, you're thinking, oh, this has to be a systemic disorder. It's a particular syndrome, because the arthritis and lymphadenopathy should make you think, when you see this finding of necrosis and then thrombosis of small vessels, you would think that this is Kawasaki disease. Even though Kawasaki disease is rare in the U.S. or in the West, it is much more common in parts of Asia. But the histologic findings are, when they're typical, are very, very suggestive of the diagnosis in this setting. And why do we want to actually make a diagnosis of Kawasaki disease? Because even though in the majority of patients it's self-limiting and they may be fine, if they do get treated appropriately, their risk of developing coronary aneurysms or coronary vasculitis gets decreased from 15% to from 25% to 3 to 6%, which is really a huge advantage and makes a real difference to treat them appropriately. Etiology still remains unknown, although based on the epidemiology and the distribution and the age, meaning that most of these patients start to get this disease after they're 6 months old, because up until 6 months, the maternal antibodies are likely protecting them. And by the time they're 2 years old, you would have an immunity. Your own immune system is working much better, so that you don't tend to see Kawasaki disease after they're 2. So the thinking is it's probably some kind of an infection, maybe a viral infection, although they have not found it. that triggers an antigen or unmasks an antigen within you that then sort of releases this antibody response or an innate and adaptive immunity. Once that immunity is triggered, the vast majority of patients would not get a repeat. So there's a 97% protection. So it sounds like an infection, but we just don't know what it is yet. The granulomatous lesions are less common in children, and it depends. Your differential, of course, depends on where you are practicing. Where I grew up in Pakistan, TB used to be at the top of our list, and we would always think of that first, second, and third. And here you would think, say, maybe cat scratch disease would be more common. But stains, as you know, are not the best. You only find them positive in about 10 to 20% of patients who are culture positive. So you do need to send for culture or, doing the stains for I see a lot of histoplasmosis in Chicago as well. But sometimes it's not an infection that you can actually really find on the tissue. So knowing the serology is helpful, knowing that the necrotizing areas have neutrophils, they have this geographic pattern, palisaded macrophages. You can suggest cat scratch and have them do the appropriate testing. However, sometimes the morphology is not typical. You still have to be thinking clinically as to what you're going to recommend. Like this patient has an enlarged lymph node, but you don't see that geographic necrosis. Maybe there are a few polys here and there, and we looked around, there's really not much, and then this case was originally signed out as non-specific changes, and then eventually they did find that the patient was serologically positive, so that really was cat scratch disease also. So clinical correlation is key. And then you do have to think of rare things that can be granulomatous, like this patient who presented with lymphadenopathy and had chronic granulomatous disease of childhood, that being the first presentation, which can occur in a minority of patients. So you do have to think of that. So finally, I want to end up with one of the things that my resident recently is in the process of publishing, it's in press now, is what's called print culture. Because if you have a frozen section, and all these years we've always said to them, you got to send it from the surgical suite. Once you have the tissue in pathology, we can't do cultures. But what he has done a study of is prospectively took tissues, not just lymph nodes, but other tissues, lung as well, and at autopsy as well, did a frozen section, and if they found necrotizing lesions or something that they thought histologically looked infectious, he would plate it. So they used, depending on what type of things you're thinking, the basic 3 plates would be a blood agar, a chocolate agar, and then a fungal, because you're thinking fungus especially if the patient is immunocompromised, you may want to do it. And you take that section, you cut extra section, and you put the whole tissue section on the plate. And then you send it to microbiology for culture. We've done anaerobic cultures as well, but you do need to have the supplies in the gross room. So we keep a supply of the 3 main plates in the gross room. Then when they culture it, if there is no growth, there was 97% concordance with no growth from what was sent from the OR. If the growth is all at the edge of the tissue, then we assume that that's contamination. And if the growth is from the middle, then those are the colonies you want to. Here is an example of a frozen section that showed an area of necrosis with inflammation, an area of viable tissue with chronic inflammation, and then an area of fibrosis. Well, this has sort of fallen apart, but when you push it together, that was the section that was put on the culture medium. So the area that was fibrotic didn't grow anything. These at the edges are probably the contaminant, and then the area that was necrotic is the one that has the heavy growth, and that was what was positive for this patient. And it correlated with the clinical culture results. So print culture can be done if you have, and it doesn't take much to do it. All you need to do is cut a couple more sections on your frozen section, put them down on the plate and send off the plate to micro. All right. So lastly, I want to also mention about these histiocytic proliferations of what is new in that. Obviously, there are vast majority of a ton of lesions in peds like hemophagocytic syndromes and the storage disorders that I won't be able to go into. But Rosai-Dorfman disease is something also that we have learned a lot of new things about recently. It is massively enlarged sinuses due to macrophages with imperipolesis, which may or may not be present. But what it is seen in children and young adults and can present as large bilateral cervical mass. They can present as extranodal site involvement. It can be progressive, just like other things. You can have less than 10% of them. But what they have found is that this multi-system disease, at least a third of them are really neoplastic because they have mutually exclusive mutations in one of these two genes, and they behave like a low-grade malignancy. So if you are thinking Rosai-Dorfman, you need to work it up further. The pattern is not classic for just this one disease. There is overlap. You can get the similar looking things in or Rosai-Dorfman-like pattern in Langerhans cell histiocytosis. You need to be doing the appropriate stains to do that. Increased IgG4 positive cells have been shown to occur in over 40% of patients with Rosai-Dorfman disease. So there is a huge overlap between these two diseases, and you need to work those out as to which one it is, and I'll show you an example. And then autoimmune lymphoproliferative disorder can also have a Rosai-Dorfman-like pattern, and that is a fast ligand abnormality, so you need to work that one up as well. So here is an example of a 16-year-old who presented with cervical lymphadenopathy. There are enlarged follicles, almost looks like, there's some rimming with those mature lymphocytes. There are increased plasma cells. And then when we did the stain, IgG4 was markedly increased. The criteria are only 10 IgG4 positive cells, but in one high power field, these are certainly more than that. And you do need to remember that the IgG4 positive cells may be localized just to the germinal centers and not be outside. So there's a sort of a pattern of infiltrate, and you almost think is that an artifact because they're like grouped in different areas, but they are grouped. So IgG4 related disease can be solitary or multifocal. It can have different patterns, and it is a clinical syndrome, and you do need to find the IgG4 level greater than 135 milligram per deciliters and multiple areas of cells with it. So finally, this is in your handout as well, just so that you have a framework of when you're starting to teach somebody, you may want to know, well, how do you put the various diseases I've sort of touched upon into the different groups. I have not been able to obviously cover any of the benign tumors that can occur in children as well. So in summary, when you're looking at a lymph node, you have to think of, is it a benign inclusion? And then what type is it? What is the pattern of involvement? You do need the clinical correlation for your workup. Your workup can be from infectious to a specific disease, to molecular, to malignancy, to IHC. It's a whole spectrum that you're going to be doing it. And then if you're thinking infection, you can always do cultures as well as special stains. I would like to acknowledge Dr. Krause and Andrea for some of the pictures that they loaned me. And this is a reflections at sunlight on my bedroom window in Chicago. So come to Chicago.